Senate Committee Room, C311.
And then hopefully our other two members will be able to join. One second, I have okay. All right, so I'm going to call this meeting to order. And do we need to take roll call? I don't know.
We can take a roll call. Denise Harris Proctor, Natalie Shorter.
Yes.
Kenda Sutton L. Delegate Tran.
Here. Okay, great. Thank you. And then I think we are going to, we last met in December and tried to brainstorm some ideas and information that we needed to be able to move forward. And one of those that we had talked about was having our own DMAS, the Department of Medical Assistance Services, come to present on what are, the insurance and Medicaid coverage for breast and cervical cancer. It was a topic that we had all coalesced around learning more about. And so I think today we have Dr. Barabel with DMAS with us to be able to present and share. Oh, I think, did we lose Natalie or is she just not on my screen? Oh, there she is. Okay, cool. Dr. Barabel, are you ready?
Yes, hi. I was trying to figure out how to blur my background, so just apologize for the mess in the back.
It's called life. It's all good.
I know.
I'm going to plug the computer in.
I didn't have the password to get in, and so no, this is everything off the bingo card on Monday. It's perfectly fine. And will you all be presenting the PowerPoint that we sent, or should I share it from my screen?
Dr. Barabel, if you're able to share from your screen, I think that would work best.
Okay. That is going to work. Sorry, I'm trying to figure out how to share and not have you all blocked. All right. Well, I can't see also. Can you see the slides?
Yes.
Okay.
I see your screen.
Yes, sir.
Okay, excellent. So I can't see the screen. So if there's any questions, Carl and Keith, you can.
Yes, we'll file them for you.
Okay. All right. Hey, everyone. Hi. I am Dr. Greg Barabel, Chief Medical Officer for DMAS since November 25th. With me, Heath and Carla Callahan present to you all about Medicaid breast and cervical cancer screening and coverage today. So a quick overview of what we're going to go over, a little bit of tag team first talking just about Medicaid enrollment, the different assistance programs that are outside of the core Medicaid benefit for women or men who encounter breast or cervical cancer, some of the stats, the introduction to the maternal and child health unit, which I was really glad that they're here so we could bring, kind of make that connection, be the go-to subject matter experts and resources, and then a little bit about quality and managed care. So jumping right in, for Medicaid enrollment, these are numbers as of June. We have 1.8 million covered lives. Average age of a Medicaid recipient in Virginia is 43. A lot of that is due to this expansion adult category we call MedX, and the category that is currently going to be going through changes with the work requirements, which we won't delve on too much here. But the women and the women receiving services can be in any of these categories or most of these categories, the expansion adults, other adult caregivers, which is we'll just talk about in a little bit about the additional programs that are there. Certainly the pregnancy related categories. Blind and disabled is higher level of need, and this limited coverage category is again something we'll talk about a little bit more and about it right now. So our Plan First program. So Plan First is a supplemental limited benefit program for people age 19 to 64, with the services specifically going towards preventing pregnancies. So it provides education and support. It covers screening Pap tests, but will not cover diagnostic Pap tests. It is purely the services have to be targeted towards the screening and things that are towards preventing pregnancy. But we'll get into kind of how that coverage is layered on top of that. And again, it also doesn't cover mammograms. So this is a national program, CDC, outside of the walls of Virginia, but still under our roof, and a program that can follow or be able to supplement the services under the Plan First. This detection program for age 21 to 64, and with exceptions, meaning that services can be broadened rather than restricted. Need to have income less than 250% of the federal poverty level. Sorry, I failed to mention for Plan First that's less than 200% of the federal poverty level, but provides the screening tests, the whole host of them, but also those diagnostic tests necessary if there is an indication on screening that further follow-up is warranted. So last within the kind of the grouping of categories that are available, the Breast and Cervical Cancer Prevention and Treatment Act program, which is a program that for women aged 18 to 64, diagnosed through this Every Women's Life, which is run through VDH, which I believe they had presented on previously, as well as a program through DC Health for serving for the Nova area, where they also have an additional cancer program screening where they can receive additional coverage. So to get into this, you have to have no coverage, no type of Medicaid, commercial insurance, or any other supplemental programs. But once you're in, it provides the same amount of services and benefits that a full Medicaid recipient would have. So some brief data that we were able to gather for the presentation. This is looking at the number of screenings that are occurring for both breast cancer and cervical cancer. You'll see that the BCC PTA, we are able to break that out separately, much smaller, right? Because a lot of times entry into that program and the billing for Medicaid, that program is more on when it's been diagnosed for the treatment side. But I can tell you that these, looking at the previous numbers, this has increased 30 to 40% over the past 5 years, which is amazing that we're really working on increasing those services.
Dr. Barbell, one second. I think we were all wondering, I don't think we see your screen anymore.
Oh,
So we saw I think the first two slides, the cover slide and then the first slide on like the different categories of Medicaid participants.
And if you like, Dr. Bearable, we can we can try to share on
that
our
would be amazing.
we can Heath, are you able? I can try if you can,
Yeah, let me see if I can pull it up real quick.
Okay.
This is my first WebEx experience in quite a while, so I'm not familiar with the sharing approach here. Let me see. Oh, there we go. Share.
Oh man, that was gonna be my big surprise.
oh.
Let me see here. Whoa, look at these. Let me go back here. Sorry, everybody. Where were we at, Dr. Bearbell?
I guess where do we get left off in terms of the slides?
I think it dropped off for me about right here on the CDC slide.
Okay, well, we'll just rewind and start with the CDC, the national program. A little bit higher of a federal poverty limit, but provides screening and diagnostic services. Oh.
It just did the same thing.
Do you think would it be possible, and Dr. Barbell, you should just continue on, but I think because we are having a public subcommittee meeting that we would have to somehow post the presentation. Am I right, Madison?
Yes, Madam Chair, the slides and all the other meeting materials, they're already available online to the public.
Oh, they are. All right, awesome. Is it, and maybe I missed it, can you just share that link? And so then at least Natalie and I can go also view it simultaneously as the doctor is presenting.
Okay, yes, of course, I will find that.
All right, awesome. All right, I think we can continue on.
I like this. This is good.
I love that.
Yeah, the first one's always got to be the most fun. So
yes.
It's gonna be memorable. All right. Well, why don't so I was just gonna say did we put the link? I don't know if there's a chat. I'm gonna try this one more time, and we're just gonna go with the. Can you all see that?
Yes.
Okay. All right, we're just gonna go with that. So, and with that, I'm gonna pass it off to our maternal child and health unit folks to give a little bit of an overview of their program.
Yeah, absolutely. Thank you, Dr. Bearbell. Sorry about all the technical difficulties, everybody. I'm Heath Kirby. This is a Tennessee accent. I've been at DMAS for a little over 4 months now as the maternal child health manager. And it's a privilege to speak with you all today. Thank you for the opportunity. I figured I'd be remiss if I didn't take this opportunity to give you all a general introduction to our maternal child health unit. So we in the maternal and child health unit at DMAS support women, infants, children, and adolescents through a continuum of care that for women extends from the antepartum or prenatal period to the postpartum period, and for children extends throughout childhood, adolescence, and young adulthood through our EPSTT benefit and our early intervention supports. Specifically for maternal health, the scope of this conversation, during pregnancy, Medicaid members have access to comprehensive prenatal care designed to monitor maternal and fetal health, identify and manage high-risk conditions, and connect families with the resources necessary for healthy pregnancies and births. Following delivery, Virginia Medicaid provides continued coverage and care for mothers through 12 months postpartum, recognizing that the first year after birth is a critical period for addressing physical recovery, behavioral health needs, chronic disease management, family planning, and social determinants that influence long-term maternal and infant outcomes. All right, next slide, Dr. Bearbell, if you don't mind. So our maternal and child health unit scope of work can be broken down into 4 main categories that this Pentagon encapsulates. So the first category is benefit and service communication to our members, providers, MCOs, and across agencies. The second category is benefit and service utilization to members, providers, and MCOs. The third category, oversight and compliance of our managed care and cross-agency partners. And then fourth category, population health improvement for our members. So benefit and service communication feeds into benefit and service utilization. Oversight and compliance ensures our contracted and interagency partners are communicating and delivering services effectively. And all this feeds into the end goal of improving population health outcomes for our members. Next slide, Dr. Bearbell, if you don't mind. Thank you. So from this scope of work, our unit has identified key goals and priority areas, excuse me, to highlight a few. Increase outreach and communication to members and providers, which falls into the aforementioned benefit and service communication category. Increase access to high quality health services for pregnant postpartum members, which falls into benefit and service utilization category. And care management for high risk health conditions, which falls into a couple of categories, but for our conversation, I'll put it into the oversight and compliance category because it's a deliverable we track across benefit and service areas. Next slide, Dr. Bearbell, if you don't mind. Thank you, sir. Our unit is leading and collaborating on a variety of different projects to accomplish our maternal health priorities. And just to highlight a few, for high-risk pregnancy, to reduce diagnostic variance and increase the standardization of care. We're partnering with VDH on a slew of deliverables. One, creating a standard definition of high-risk pregnancy. Two, create a core set of contributing risk factors for high-risk pregnancy. Three, creating a screening assessment tool to identify high risk among our MCOs. And 4, creation of unified referral pathways for members. To reduce maternity deserts across the state, which is a priority of a variety of our listed projects here. We're working on a few projects specifically, though, in the reduction of maternity care deserts space. One being the National Academy for State Health Policy, NASHP, Maternal and Child Health Policy Innovation Program, PIP, with VDH to identify national best practice solutions we can bring to our state to address maternity care deserts. And additionally, the formation of perinatal health hubs with VDH to provide community-based wraparound supports and services to pregnant and postpartum women and their infants. Next slide, please, Dr. Bearbell. Thank you, sir. One of the listed maternal health projects the MCH unit is prioritizing is our doula benefit. So increasing doula provider enrollment and doula service utilization is a also a central component of a few of the projects listed on the previous slide. As I'm sure you all know, the body of evidence demonstrates doula support during and after pregnancy is associated with improved maternal health outcomes, including increased use of prenatal care, lower rates of cesarean delivery, reduced preterm birth, higher rates of breastfeeding initiation, and just general greater satisfaction of the childbirth experience. The doula benefit is a few years old, and HB 838 recently codified the benefit. Through the benefit, our members have access to up to 10 prenatal, postpartum visits, doula support during labor and delivery, and doula linkage to care supports for the new mom and baby. In the MCH unit, we have personnel specifically dedicated to operationalizing the doula benefit, and we're currently in the process of finalizing our doula strategic plan to increase provider enrollment and service utilization, as well as publishing our doula provider manual to support providers with enrollment and understanding of covered services and billing. Next slide, Dr. Bearbell, if you don't mind. Thank you, sir. Cardinal Care is our mechanism for service delivery to our members, and we partnered with 5 MCOs to provide member benefits and services: Aetna, Anthem, Humana, Centera, and United Healthcare. Next slide, please. Thank you, Dr. Bearbell. And we communicate benefits and services to our members in a variety of ways, both online and physical, tangible mailings that we send, 2 of which are displayed here. On the right, we have our new mom letter. We receive notification of members who have transitioned into the pregnancy aid category, and we welcome the new mom to managed care with information and a list of best practice recommendations for their pregnancy journey. On the left, we have our enhanced benefits health plan comparison chart. We worked with the MCOs to detail the enhanced benefits each health plan offers. So that's on top of the basic services offered across health plans to help members make informed decisions when choosing their health plan. Back to you, Dr. Bearbell.
Dr. Bearbell, I believe you're on mute.
Totally got a bingo. Managed care holds about 90% of the population for Virginia Medicaid recipients. And even with that 10%, many of them are just transiently in the fee-for-service program prior to being assigned to a managed care organization. And as part of the contract and dollars we give them, they focus on both rehabilitative and habilitative care, screening, treatment, diagnosis, and they have a lot of identification strategies to help to target individuals to receive certain services. And breast and cervical cancer is no different. So you may or may not have heard of HEDIS metrics, healthcare effectiveness data integration set. Originally, it was designed by organizations that were getting healthcare coverage as a way to monitor whether the dollars they were paying were actually going towards this preventive treatment. Now it's kind of been turned around where it's what the federal government uses for to evaluate the states, as well as the states we use our contracts, and the contractors, the MCOs down to the providers, in a way that has defined technical specifications of what's needed for care. And we're going to go into that a little bit after. Predictive modeling, and now obviously going to kind of the world of AI, but heuristics and kind of data algorithms to be able to identify people who have needed services, be able to provide predictive metrics on whether or not they're going to fill those, or people being able to identify people who are at higher risk for need for a screening service such as breast or cervical cancer. Certainly, they look at the claims, the utilization data. Health risk assessments, are important tools, used on the front lines, both by the managed care and the providers. And then, those health risk assessments will dovetail into, provider referrals. But really the the most kind of direct way that we look at breast and cervical cancer screening is through these HEDIS metrics. And so they are constricted. So for cervical cancer screening, look at the number of women aged 21 to 64 have had cervical cytology performed within the last year. That's why when if we went back to the screening numbers, say, well, that seems low for the number of women who could be screened, but also there is this temporal quality to it. Or now with the updated tests, right, the HPV tests within the last 5 years. This information is from 2024. With HEDIS, usually lags about 18 months behind before they're finalized and released. And we are tracking. Molina now has been replaced by Humana, but we are a bit lower than the national 50th percentile. However, these are rates that have been slowly increasing over the past 3 years. And for this metric, as well as the next one to present, the breast cancer screening, those are under consideration to be added onto the performance incentive program that we have with the managed care organizations. One of which is required dedicated focus and performance improvement on these HEDIS measures. So we are now considering adding this one, as well as the breast cancer screening. Women 50 to 74 had the mammogram onto that suite of measures that are part of their performance incentive program. We'll stop there for any questions or discussion. You could take the whole range of topics is open.
Can I ask on the breast cancer screening, is this every women who've had a breast cancer mammogram within the last year, or how many years?
This would be within the last year. It goes by calendar year.
Okay. And then the cervical cancer screening was within the last 3 years, which looks like what the recommendation is to have it between 3 to 5 years.
And right, and so within that one, it would be within a calendar year, you would get credit for the women who had it within the last 3, and then your numerator would go up for the women who were due in that calendar year. That makes it. It's kind of almost like a rolling average in that the measure is looking at just in this year of 2026, how many women how many women met the metric of having a cervical cancer screening within the last 3 years. So like January 1, all the women who had it in the year before and the year before that, they're already counted, right? So right, and so it I like metrics like that a little bit better because it gives you a sense of both baseline and where your movement is. It's not like like a preventative healthcare visit where on January 1st everyone you're at 0%, right? So it helps to target in and to see like where your moving average is. I could probably show that better in data outside of this.
Okay. But what this shows, and I want to invite others, and Natalie, if you have questions, please jump in. But what this shows is that we are generally women in cardinal care are, except for, I'm sorry, I need my reading glasses, health keepers and Aetna Better Health, but like in some of these other groups, less than 50% of the women are getting the timely screenings that they need?
No, so this is the percentile, meaning that the kind of within the normal curve of the state. So I would need to go back, but this could mean this does not translate to 50. Let's say 50% of the women are getting the treatment. It's the 50th percentile. So if we're right in the middle, so it actually may mean that it's 70% of women are getting it, but that's just kind of where we are compared to the states. Let me stop sharing. I'll pull something up. But your question is valid, and to get that's the percentiles are giving us a sense of where we are as compared to other states, right? But the, what is the actual percent? Is it 10% of women? Is it 90% of women?
I think I need that slide in plain
Yeah.
language, the interpretation of that slide in plain language, but that's okay. I don't know, Natalie, do you have any questions or thoughts?
Yeah. As we're thinking about and speaking on prevention, was thinking, what is, doctor, that you see the single greatest barrier, I guess, preventing Medicaid maternal health programs from closing outcome gaps, specifically for Black women, women in rural areas, whether it be awareness, provider capacity, transportation, reimbursements, or something else?
Actually, I'm going to give Heath an opportunity to jump in, kind of into this whole program, and then I'll fill in after.
Yeah, I would say access to care, specifically in our more urban and rural, hyper dense urban communities and hyper low density rural communities, access to care. Provider shortages that lead to maternity care deserts. We have a variety, as mentioned in my portion of the conversation, we have a variety of different initiatives in our maternal child health unit focused specifically on increasing provider networks, number of providers in our identified maternity care desert regions, so we can increase access and utilization of care for our member populations. And it's usually our member populations, individuals who qualify for Medicaid, who are experiencing the most disparity as it relates to access to providers and utilization of care. So one huge initiative that our maternal and child health unit is currently in the process of tackling with our sister agencies and our cross-agency partners is reducing the number of maternity care deserts in Virginia.
Mm-hmm. Mm-hmm. Okay. So realizing that access is an issue, of course, that's being looked into, but I think I'm like doing way too much right now. I'm reading everything that was in the link. So do we have data showing whether utilization of Medicaid services is actually improving these outcomes in these areas and other high-risk populations? And specifically, where are we seeing reductions in like severe maternal morbidity, maternal mortality, emergency department utilization, and among Medicaid members who access the services versus those who don't?
You're saying just kind of generally overall, or specific to the breast and cervical cancer?
I guess both, maybe.
Yeah. Yeah. I mean, I think there's, when I've been thinking, there has been certainly just if you talk didactically, the presence or absence of coverage. We know that there are poor outcomes for women who get Medicaid coverage much later within their pregnancy, close to the third trimester than the first. Those screening components absolutely matter. Even I think out of this 8 kind of required or recommended by ACOG, right? Once, if you have less than 4, then that's an indicator, and that's again with the care that that the services themselves are having a positive effect on the pregnancy. Another component that we're just now kind of leaning to is the extension of Medicaid coverage for 12 months postpartum, and so this is an opportunity where we're being able to kind of look in to see the effect for the mother, and certainly mental health is mental health issues are the number one cause of death in the postpartum period. And so being able for the MCOs to use those algorithms to identify people who could qualify or would be eligible and need the services is extremely important. I think one of the components that I'm excited about as a geeky coder is that we're moving from looking at the medical services within the pre and postpartum period as a bundle, right? So you submit one code and you get paid for all the services. That we're moving into kind of discrete billing. So understanding like the individual touches and to your point, being able to kind of better dig down into, when service is being delivered, what is the level of quality, right? Are we getting the outcomes that we're looking for? So, I wouldn't be working here, if I wasn't a firm believer that the provision of the services and Medicaid access is an important component. I think, being here and presenting with you all today is the opportunity, to hear kind of and bring back what you want to see, right? And within, and kind of first off, just what is the actual rate of screening? Which I believe is about 78% from the VDH website. So, but yeah, it's 1.8 million members, millions and millions of claims coming in each month, and so there's a lot of noise, right? But we want to work with you all to find where that signal is.
I think you just said, Dr. Barbell, that the screening rate, is this for breast cancer or cervical cancer, 78%?
For breast cancer, 78%.
Okay. Okay, so maybe that's kind of like the plain language of those two charts you showed us so that we could better understand. Do you know what is the national average and how do we compare?
Also right around 78%. So we're 25th out of the 25 out of 50 states.
Okay.
Adding to Natalie's question, I plugged a public-facing report in the chat here that is our annual maternal child health focus study report, which looks at birth outcomes over the course of 3 years, calendar year 2022 to calendar year 2024 is the most recent publication. Birth outcomes by region, accessibility of care by region, and this report is compiled for us. We collaborate with the compilation of it, but it's compiled with an external quality review organization, HSAG, Health Services Advisory Group, that we hire to evaluate our services rendered, as well as the efficacy of our outcomes.
Okay, thank you.
I do have one last question, and I think Kendra is on. I think I'm not sure if I see Kendra's box, but it sounds like she's trying to get on or trying to be able to participate as well. So flagging that for our staff. I think one of the slides had some materials that you want to share around women's health and the services that are available for Medicaid participants. How do we translate that information so that our whole universe of Medicaid participants here in Virginia are able to access it?
The health plan comparison chart in the flyer, or
just I thought there was a slide on here, some information we are trying to disseminate around care and how to take care of yourself and things like that. How do you all translate that?
Well, I think for the majority of the information, it's the managed care organizations are taking the lead on sending that out, and ours is actually like that the enhanced benefits. It's the health plan comparison chart. That was a compilation and something that we provide on the front end to help members to choose a health plan that fits with their with their needs. But it's absolutely multimodal. I came back in my day, but from the health plan side, right? And we're doing besides mailers, doing phone calls, radio ads, going to community events, and holding community events. And so there's a lot of kind of movement and focus around maternal child health, both at DMS. I think as evidenced by a dedicated unit and stealing one of the best from Tennessee, as well as the MCOs also having that focus.
Yeah. Good morning, everyone. Carla Callahan, Assistant Division Director for Healthcare Services. This has been a great discussion, and we're happy to be here to present and also obviously answer questions. I would just add on to what Dr. Bearable mentions as far as communications. Yes, our managed care organizations help with communications with the MCOs, with the members, but also here at DMAS, we share communications directly with our members through mailings, social media. So definitely we realize that, our connection and reaching members and making sure they know about the delivery of services and array of services that we have. And, we're always looking for strategies on how do we kind of meet members where they are, where that is, social media, text messaging. I know the managed care organizations have portals where they can push information to members. So that is, a great way for it to have engagement. So just wanted to make that note. And also, in addition to our enhanced benefits comparison chart that we have for just maternity, we also do have a general comparison chart that is also mailed out to members as well. And those are posted on our virginiamanagedcare.com website from our enrollment broker Maximus. It's posted there. So I can pop that in the chat as well if that would be helpful.
Thank you. And thank you for both, the reminder that there's the communications that DMAS does directly, and then there's the communications from the managed care programs as well. I think when we talk about access to care, for me, it's both the physical access, right? The ability to see your care provider and get the actual services you need, but it's also the language access so that all the things that you have as benefits and also what you need to do to take care of yourself. And I think we in Virginia still struggle with the language access piece and the physical access piece, but just on language access, we still struggle with how to do that uniformly across all of our benefit programs. And just thinking about kind of the vulnerable communities that are tapping into the Medicaid program is just, a constant urge for us to figure out how we can do more of that outreach for folks. That's all. All right. I think Kendra is just for our staff team is on. I believe she might be on a phone, so I don't know if she's going to have the ability to unmute for questions, but just a heads up. All right. Natalie, do you have any more questions or thoughts for our guests? Okay.
No,
Thank you
I'm
so
good.
much. Thank you so much to the DMAS team. I think what you shared was really gives a really good oversight of what's happening with the Medicaid program around breast cancer and cervical cancer screenings. We will not be shy in following up if we had questions and thoughts for next steps.
Yes.
We appreciate the mulligan.
Yeah.
Thank you all for the opportunity.
Yes, we appreciate it.
Thank you.
Bye. All right, so I think the next part of our, so I'm just going to go, next part of our agenda is to hear about relevant legislation from the 2026 session. Turn over to Madison.
Yes, thank you so much, Madam Chair. I will go ahead and share my slides that I have. Great. Mm, Get this. Sorry, just trying to get this right. Having a day with technology today.
Hey, y'all, I'm here. I'm gonna turn my camera off, but I gotta go grab my charger real quick, okay? For my laptop.
Okay. Um, mm, okay. I can wait until Miss Shorter gets back, or I can go ahead and start Madam Chair.
Yeah, we can give her a minute.
Okay.
After this next portion, Madison, okay, so discussion of invitations. All right, cool. Look at ideas for the next meeting. Okay.
Okay. Yep.
June. Okay, maybe you can go ahead and get started, and then when Natalie comes back, she'll catch up.
Okay. All right. Perfect.
Oh, I'm
So-
here. I'm sorry. I'm here.
All right, sounds good. I'll go ahead and get started. So as Madam Chair explained, I will be doing an overview of legislation that came through the 2026 General Assembly session that covers relevant topics for the Preventative Care Subcommittee. I will try to keep this as brief as possible because I know we have some other agenda items, but just go ahead and feel free to stop me or jump in if anything, if you have any questions. So first, I will go through the legislation that passed. So we have House Bill 6 and Senate Bill 596. That was Delegate Price and Senator Carol Foy. This establishes a right to obtain contraceptives and engage in contraception as such terms are defined in the bill. A healthcare provider shall have the right to provide contraceptives and contraception related information to the extent the provider is properly licensed and acting within the scope of the provider's professional practice. The bill also clarifies that none of its provisions shall be construed to permit or sanction the performance of any sterilization procedure without a patient's voluntary and informed consent. This bill creates a cause of action that may be instituted against anyone who infringes on such right. This bill passed the House on a vote of 65 to 32 and passed the Senate with a substitute on a vote of 23 to 15 and was signed by the governor on April 8th, 2026. The second bill I have is House Bill 425 that was by Delegate Livier Bowling. This expands provisions for payment of medical assistance for remote patient monitoring services provided via telemedicine to include high-risk pregnant persons, defined as those pregnant persons 35 years or older through 12 months postpartum. The bill directs the Department of Medical Assistance Services to assess expanding similar provision of payment for patients with advanced maternal age and submit a report of its findings to the General Assembly no later than November 1st, 2026. This bill passed the House on a vote of 95-1 and also passed the Senate unanimously, and was signed by the governor on April 8th, 2026. The next bill I have is House Bill 652 and Senate Bill 133. That was by Delegate Hayes and Senator Locke. This bill directs the Department of Social Services, the Department of Behavioral Health and Developmental Services, the Department of Health to convene a work group to evaluate the Commonwealth's response to paternal, prenatal, and postnatal substance use. The service is available to address such substance use and the effects of such substance use on newborns and children. The work group will also submit a written report of its findings and recommendations to the Senate Committees on Education and Health, Rehabilitation and Social Services, and the House Committee on Health and Human Services by December 1st, 2026. This bill passed the House on a vote of 65-32. And Senate Bill 133 passed the House on a vote of 80-18 and also passed the Senate unanimously. The bill was signed by the governor on April 13th. The continuing past legislation, we have House Bill 998 that was by Delegate Siebold. This bill requires that each package or box containing menstrual supplies contain a label of all ingredients that are included within such products that are sold within the Commonwealth. Such label shall be displayed by the manufacturer in a manner that is visible and easy to understand for the consumer. The bill requires any manufacturer to make changes to the label reflecting any changes of ingredients within 18 months of such change taking place. The bill also requires the manufacturer to post the required label information on its website, and this bill has a delayed effective date of January 1st, 2027. This bill passed the House on a vote of 69-28, passed the Senate on a vote of 24-16, and was signed by the governor on April 6th. The next bill that we have is House Bill 1353. That was by Delegate Cohen. This bill directs the Commissioner of Health to convene a work group of relevant stakeholders as described in the bill to evaluate the feasibility of a statewide maternal health safety initiative. This includes representatives as defined in the bill and also directs the commissioner to submit an interim report of the findings of the work group by November 1st, 2026, and a final report with the work group's recommendations no later than July 1st, 2027 to the House Committee on Health and Human Services, the Senate Committee on Education and Health, and the full Commission on Women's Health. This bill passed the House and Senate unanimously and was signed by the governor on April 13th. The last passed legislation that we have is House Bill 1400. That was by Delegate N. Franklin. This requires health insurance carriers to provide coverage for maternal mental health screenings. The coverage must include at least one maternal mental health screening to be conducted during pregnancy and at least one additional screening to be conducted during the first 6 weeks of the postpartum period, and additionally, medically necessary postpartum screenings. The bill also provides that coverage for a prescription drug for the treatment of a maternal mental health condition shall not be subjected to prior authorization requirements unless there are clinically significant safety or efficacy concerns. This bill passed the House on a vote of 66-30 and passed the Senate unanimously and was signed by the governor on April 13th. Lastly, I will move to failed legislation. The first one that I have is House Bill 1468 that was by Delegate Lavier Bowling. This bill would have required health insurers, corporations providing healthcare subscription contracts, and health maintenance organizations whose policy, contract, or plan includes coverage for obstetrical services to provide coverage for doula care services provided by a state certified doula. This coverage would have included at least 8 visits during the antepartum or postpartum period and support during labor and delivery. Under the bill, health insurance carriers would not be required to pay for duplicated services actually rendered by both a state certified doula and other healthcare provider, and also prohibited from requiring supervision, signature, or referral by any other healthcare provider as a condition of reimbursement for doula care services, except for when those requirements are applicable to other categories of healthcare providers. This bill was stricken from the docket of the House Labor and Commerce Subcommittee number 1 on a vote of 9-0 on February 10th. And then going to the last bill that we have is Senate Bill 168 by Senator Craig. This bill would have created an exemption to certificate of public need requirements for any project or action related to maternal and perinatal health services. The bill would have also removed neonatal intensive care from the definition of tertiary care for the purposes of determining health planning regions. And this bill was passed by indefinitely by the Committee on Senate Education and Health. And so those are all of the relevant legislation that I have. If there are any questions, feel free to let me know. We also have our wonderful 2 attorneys, Bert Allwine and Sabrina Miller-Bryson. They are not on this call, but they are also available to answer any questions about legislation or any of the other matters pertaining to this presentation if I cannot. But that is all I have for you.
Great, thank you so much. Do you have any questions, Natalie? No, you're good? All right. I know there are a lot of really good bills this year, I think, that tackled health issues, and I'm so glad you were able to highlight these for us, Madison. I have particularly because there's so many good bills, I'm really glad you reminded us about House Bill, I think it was 1400 from Delegate Margaret Franklin, about the postpartum maternal health screenings, but also including postpartum screenings. It's really cool. A lot of good work. Awesome.
I actually do have a question.
Yeah, go ahead.
As the bills are being implemented, post-session and onward, are there any metrics in place that we will use in Virginia to determine whether the legislation is actually reducing maternal health disparities in high-risk populations? Is there a way to, are we watching that?
I will say for a few of the bills that are going directly to sort of study some of those effects of maternal and postnatal care. So for a few of those reports, we will get those, studies going back to the commission, especially for House Bill 1353 was one of those that will sort of help to determine the feasibility of the maternal health and safety initiative. So we will get sort of a good progress on their report when they submit that for their first year. That will be November 1st. And then also when they submit their final report on July 1st. So we will, get some good feedback and reports based on some of the studies and their findings from that as well.
Okay. Thank you, Madison.
Okay, so I think the next part of our agenda is to brainstorm. Are there other presentations or data requests that we have at this time? So it sounds like from what you just asked, Natalie, maybe once the reports are due back to, if we're able to meet in December again, is to get a readout on some of those reports, Madison, that are statutorily required in November.
Yes, absolutely. I believe that we have to finish our interim work this year by November 30th, but we should be getting a few of those reports earlier in the month. So if we have a full commission, by the time that we have those, then we can definitely just do sort of a brief overview of those findings.
Okay, cool. And then other topics. I had a question about when you were talking about Delegate Margaret Franklin's bill, it made me recall, I believe that VDH is implementing a communications campaign right now to let folks know about postpartum services that are available. And this is work that former Delegate Munden King had done the other year. So I think that campaign kicked off, I want to say sometime either in May, might have been May. So I was wondering if maybe they could come and give us an update on how that's been going and what they're seeing and hearing as they are providing additional information out to the communities about postpartum care and how important that is.
Yes, of course. We can definitely send that request for them to come and speak, so I can put that in as well.
Thank you. And then Kendra's question was generally for DMAS, but I think they're off now. If how are they engaging with community partners who work directly with folks? Is there a process where we're focusing on the quality of the delivery of services, not just the quantity? So maybe if there's an opportunity where they come back in the future to talk about other programs in the Medicaid, other services under Medicaid, we can make sure that's addressed.
Okay, yes, definitely, Madam Chair. I can also submit those questions to them as well as a follow-up. And
Okay, and see if they can give us a written response. Cool.
Yes.
All right, cool. I know, Natalie, are there like specific data points or topics that you hope we would cover or get more information on in our next meeting?
No, not that I can think of right now. But if I do, I'll be sure to text you or email you or whatnot.
Okay, cool. And we talked about, I'm just looking at our report. Our report from in December to see if there are additional topics that we could talk about. Well, I think we have one for you to start with is on the postpartum care, Madison, and I think as we are thinking about when the next meeting is, I know additional ideas are definitely going to be popping up, and we'll share. We can always email you with some thoughts and potential presenters. I think this, I think one of the things we had talked about in December, if there's a way to help us understand what's happening in that space, is there just around, what are age appropriate screenings and counseling around physical and emotional changes associated with puberty? So how are we connecting on health issues with our teens, so that we are having, conversations with our teens about their health, and how they can, all the things we have to do throughout our lives, the rest of our lifespan, to take care of ourselves, but starting that conversation early. I think it would be of interest.
Is that for me, Kathy?
No, I was just saying to Natalie, I think that's to Madison, that is something I'm interested in. I see your boxes.
Okay, yes, perfect. Well, I will definitely note that down as well, and can look into presenters to just come in, focus more on just, age appropriate screenings and taking care of, health across the lifespan.
Yeah. What's the best way? Because there's so many ways to have conversations with younger youth and younger adults. How do we do that well? Okay. Cool. All right. Any other thoughts on? Okay, so I think we should also think about when we meet next. And maybe has the larger commission identified a date yet when we will come together?
I have not received any communication yet on dates, but I will just send out that poll whenever we have some dates available from our Madam Chair on dates for the full commission.
Okay, so maybe we can, when there's a date for that, we can backtrack and see when is a good time for us to meet next. Okay, cool. All right, so at this point we have public comment. Did anybody sign up to provide public comment?
Madam Chair, we have 3 attendees online for public comment.
Okay, great. I don't think I could see them. Oh.
Brittany Whitley, you can unmute, turn on your camera, and provide your comments.
Apologies, I did not mean to sign up for public comment when I registered.
Catherine Haynes, you can turn on your camera, unmute, and provide your comments.
Like Brittany, I did not mean to sign up for public comment, merely present. Thank you.
Peyton Lyons, you can unmute, turn on your camera, and provide your comments.
I also did not mean to sign up for public comment, just listening in.
That concludes our attendees, Madam Chair.
Great. Thank you so much. And thank you for listening to this conversation and this meeting. All right. So I think that we have walked through our agenda for today. Is there anything else, Natalie, that's top of mind for you?
Not at the moment, no. Thank you, Madam Chair. I appreciate it.
Yeah. Madison, is there anything we should be thinking about as the one who keeps us on point?
Nothing else that I have at the moment, Madam Chair, but if there's anything else that you need from me or any other ideas, feel free to reach out, or if there's any other information I can provide, then I will definitely do so.
Okay. Can I add one more to this lifestyle? I'm sorry, because I've been like eyeballs deep in perimenopause and menopause issues, and I know that's come up in some of the other subcommittees. I don't think that it like naturally fits into ours because I don't think you can prevent. I mean, it would be really amazing if somebody could prevent perimenopause or menopause from happening. But I think like there's probably a lot that you can do to take care of yourself during this phase that can lead to other potential health conditions later on if you're not addressing it now, right? Like bone density and other things. So I just want to flag that as probably a thread through a couple of the subcommittees. And in a different subcommittee, I'm on Madison, we owe you a list of potential speakers. I'll talk to you about that. All right. Okay. With that, I think we are adjourned. Thank you, everyone.
Thank you, Madam Chair. Madison.
Yes, thank you, Madam Chair.
Thank you for joining us. This concludes this broadcast of the Senate of Virginia in Richmond, Virginia.